Welcome to our channel, Medicine A to Z. Today, we are going to discuss all about vitamin D. Sources of vitamin D. Sunlight exposure. 80–90% of our vitamin D comes from sunlight. Spend time outdoors to boost your levels naturally. Diet. 10–20% comes from foods like fatty fish, egg yolks, and fortified products. Supplements. The amount from supplements varies based on individual needs. Factors influencing vitamin D, synthesis and absorption. Geographical location. People living further from the equator may have less exposure to UVB rays, especially during the winter months. Skin pigmentation. Individuals with darker skin have more melanin, which can reduce the skin's ability to produce vitamin D from sunlight. Age. Older adults have a reduced capacity to synthesize vitamin D from sunlight. Lifestyle. Indoor lifestyles, use of sunscreen, and clothing that covers most of the skin can reduce UVB exposure. Dietary habits. Vegetarians and vegans might need to rely more on fortified foods or supplements to meet their vitamin D needs. Related terms. 7-dehydrocholesterol, found in skin, precursor of vitamin D3, vitamin D2 ergocalciferol, vitamin D3 cholecalciferol, calcidiol, 25-hydroxycholecalciferol. Intermediate of vitamin D synthesis, cholecalciferol, converted in the liver to 25-hydroxycholecalciferol. This is measured in blood to measure the vitamin D level. Calcitriol, 1.25-dihydroxycholecalciferol, active form of vitamin D. Vitamin D synthesis begins when our skin is exposed to ultraviolet B, UVB rays from the sun. When UVB rays strike the skin, they convert a cholesterol derivative called 7-dehydrocholesterol into vitamin D3, also known as cholecalciferol. Next, vitamin D3 travels through the bloodstream to the liver. In the liver, it undergoes its first transformation. Here, an enzyme called 25-hydroxylase converts vitamin D3 into 25-hydroxyvitamin D, often abbreviated as 25-OHD. This form of vitamin D is the main circulating form in the blood and is what doctors typically measure to assess vitamin D levels. The journey doesn't stop there. The 25-OHD travels to the kidneys, where it undergoes a second transformation. An enzyme called 1-alpha-hydroxylase converts 25-OHD into its active form, 1.25-dihydroxyvitamin D, also known as calcitriol. Calcitriol is the form of vitamin D that the body uses to regulate calcium and phosphate levels in the blood, promoting healthy bone formation and maintenance. Mechanism of action. Calcitriol exerts its effects by binding to vitamin D receptors located in the nucleus of cells. Once bound, it acts as a transcription factor, modulating the expression of genes involved in calcium transport, such as calmodulin and TRPV6. These calcium transport proteins enhance the intestinal absorption of calcium, ensuring that our body gets the calcium it needs from our diet. Calcitriol also directly stimulates osteoclastic activity, which increases bone resorption. This process releases calcium from bones into the bloodstream, helping to maintain proper calcium levels. Additionally, calcitriol increases renal reabsorption of calcium and phosphate, further contributing to calcium balance in the body. When calcium and phosphate levels in the blood drop, the parathyroid glands are stimulated to release parathyroid hormone, or PTH. PTH plays a crucial role in restoring these levels by several mechanisms. Firstly, PTH increases the production of 1.25-dihydroxycholecalciferol, the active form of vitamin D. Active vitamin D, or calcitriol, then enhances the absorption of calcium and phosphate from the intestines into the bloodstream, ensuring that the body gets enough of these essential minerals from the diet. Secondly, vitamin D increases the reabsorption of calcium and phosphate in the kidneys, reducing the amount excreted in urine and thereby conserving these minerals within the body. Finally, PTH stimulates osteoclastic activity in the bones. Osteoclasts break down bone tissue, releasing calcium and phosphate into the bloodstream. This process, known as bone resorption, helps to quickly increase the levels of calcium and phosphate when they are low. Other functions of vitamin D supports good immune function and reduces the risk of autoimmune diseases. D deficiency can cause muscle weakness, wasting, and unstable gait. Vitamin D deficiency increases the risk of type 1 and type 2 diabetes. Low vitamin D levels are linked to a higher risk of metabolic syndrome, including high blood pressure. Vitamin D helps prevent cancer by stopping cell cycle genes, promoting cell death, apoptosis, and reducing tumor growth and spread, angiogenesis. Vitamin D sufficiency. A level of 25 OHD, greater than or equal to 20 nanogram per milliliter or 50 nanomole per liter, is generally considered sufficient for skeletal health. Vitamin D insufficiency. Levels between 12 and less than 20 nanogram per milliliter or 30 to 50 nanomole per liter indicate insufficiency. This range suggests that while not deficient, the individual might not have optimal levels of vitamin D for bone health. Vitamin D deficiency. A serum 20 OHD level of less than 12 nanogram per milliliter or 30 nanomole per liter is considered deficient and is associated with a higher risk of bone problems such as rickets in children and osteomalacia or osteoporosis in adults. Vitamin D toxicity. Risk. On the other end of the spectrum, there is a risk of vitamin D toxicity. This can occur when serum levels exceed 100 nanogram per milliliter or 250 nanomole per liter, particularly in adults ingesting substantial amounts of calcium. Such high levels can lead to hypercalcemia and associated health issues. White population. Approximately 61% of individuals in the white population experience vitamin D insufficiency. Black population. The prevalence is notably higher among the Black population, with about 92% experiencing insufficiency. Mexican American population. Among Mexican Americans, the prevalence is around 81%. Other populations. For other racial and ethnic groups, the prevalence is approximately 79%. Causes for vitamin D deficiency. One of the primary causes of vitamin D deficiency is dietary insufficiency. This can occur when the diet lacks foods rich in vitamin D, such as fatty fish, fortified dairy products, and egg yolks. Several conditions can lead to malabsorption of vitamin D, gastric bypass, and surgeries. Procedures like bariatric surgery or gastrectomy can reduce the stomach's ability to absorb vitamin D. Small bowel disease. Conditions such as celiac disease or Crohn's disease affect the small intestine's ability to absorb nutrients, including vitamin D. Pancreatic insufficiency. Diseases like chronic pancreatitis can impair the pancreas's ability to produce enzymes necessary for vitamin D absorption. Decreased skin synthesis of vitamin D is another significant cause. This can result from inadequate sunlight exposure. Limited exposure to sunlight reduces the skin's production of vitamin D. Full sunscreen use. While sunscreen is important for protecting skin from UV damage, it also blocks UVB rays necessary for vitamin D synthesis. Darkly pigmented skin. Higher melanin levels in darker skin reduce the skin's ability to produce vitamin D from sunlight. Another cause is defective 25-hydroxylation, where the liver cannot effectively convert vitamin D into its active form. Cirrhosis. Liver conditions such as cirrhosis impair the liver's ability to perform this conversion, leading to deficiency. Increased catabolism of vitamin D into inactive metabolites can lead to deficiency. This can be caused by anti-seizure medications. Certain medications used to treat seizures can increase the breakdown of vitamin D, reducing its availability in the body. Another cause is the loss of vitamin D binding protein, which is crucial for transporting vitamin D in the bloodstream. This can occur in conditions such as nephrotic syndrome, defective 1-alpha hydroxylation, which is essential for converting vitamin D into its active form, can also result in deficiency. Causes include hypoparathyroidism, kidney failure. Chronic kidney disease or failure hampers the kidney's ability to perform 1-alpha hydroxylation. 1-alpha hydroxylase deficiency. This genetic disorder, also known as vitamin D-dependent rickets type 1, directly affects the enzyme responsible for this conversion. Lastly, some individuals have a defective response to calcitriol, the active form of vitamin D, at the target organs. This can be due to hereditary vitamin D-resistant rickets. Also known as vitamin D-dependent rickets type 2, this genetic disorder leads to resistance to calcitriol, preventing the body from utilizing vitamin D effectively. Main two categories of vitamin D deficiency. 1. Rickets in children. 2. Osteomalacia in adults. All these conditions depend on the magnitude of vitamin D deficiency and the time period. Calcipenic rickets is a group of disorders where the supply of calcium or its absorption in the intestines is insufficient to meet the demands imposed by bone growth. This leads to weakened and soft bones, causing skeletal deformities and growth issues. While vitamin D deficiency is the most common cause of rickets, it's important to recognize that there are several other causes as well. Dietary vitamin D deficiency. Inadequate intake of vitamin D through diet is a primary cause. Foods rich in vitamin D, such as fortified milk, fatty fish, and egg yolks, are essential for preventing deficiency. Dietary calcium deficiency. Similarly, insufficient dietary calcium can contribute to rickets. Calcium is crucial for bone mineralization and growth. Deficiency of 1-alpha-hydroxylase. This enzyme is responsible for converting 25-hydroxyvitamin D into its active form, 1.25-dihydroxyvitamin D. A deficiency in 1-alpha-hydroxylase impairs this conversion, leading to inadequate active vitamin D levels. 25-hydroxylase deficiency. This enzyme is necessary for the initial step in converting vitamin D into its active form. A deficiency in 25-hydroxylase can also lead to rickets. Hereditary resistance to vitamin D, HRVD. This condition is caused by dysfunction of the vitamin D receptor. Even with adequate levels of vitamin D, the body cannot utilize it effectively due to receptor resistance, leading to rickets. Clinical features. Most of the clinical features are due to defective bone mineralization due to calcium and phosphate deficiency. Stunted growth, odd-shaped skull, spine deformities, pigeon chest, odd-shaped ribs, wide elbow joint, wide wrist joint, pelvic deformities, bowing of the legs. Osteomalacia in adults, bone disorder, characterized by decreased mineralization due to hypocalcemia, hypophosphatemia, or direct inhibition of the mineralization process. Clinical features. Most of the time it is asymptomatic. Bone pain and muscle weakness, bone tenderness, fracture, difficulty walking and waddling gait, muscle spasms, cramps, a positive Chvostek's sign, tingling, numbness. Vitamin D replacement guidelines. Effective vitamin D replacement is crucial for maintaining optimal health. Here are the recommendations based on serum vitamin D levels. If your serum vitamin D level is less than 12 nanogram per milliliter, it is recommended to take 25,000 to 50,000 international units of vitamin D weekly for 8 weeks. After this initial period, switch to a maintenance dose of 800 IU daily. Check your vitamin D levels again after 4 months to ensure they have improved. For serum vitamin D, levels between 12 and 20 nanogram per milliliter. Take 800 to 1,000 IU of vitamin D per day. Recheck your vitamin D levels after 4 months to monitor progress. If your serum vitamin D levels are between 20 and 30 nanogram per milliliter, a daily dose of 600 to 800 IU of vitamin D is recommended. Regular monitoring and adjustment of the dosage might be necessary based on follow-up results. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.